Well, I'm Kriegsman. I'm the medical director of the BHN Springfield OTP. I'm here with Kaitlyn Spall, Bachelor of Science, recovery coach, methadone patient and advocate, as well as Carissa Cutler, LICSW, clinical supervisor for BHN Springfield OTP. And the title of our talk is The Final Rule, Defining Active Substance Use Disorder. And as we started working on this talk for the last couple of months, Kate, Carissa, and I, we sort of realized that we had an alternative title, which I'll share with you now, which is really how to provide patient-centered, individualized care in a large, low-barrier urban OTP, informed by the guidance of the final rule. And so a lot of what you'll hear today is how we've been responding to the final rule in our clinic for the last 6 months. Our hope is that you might find something you can take away back with you to your clinic. And really, we're going to do this using take-home doses as a case study. Cool. I think, again, all of us are familiar with the 42 CFR Part 8 final rule. Really 4 main themes that we look to: promotes practitioner autonomy, removes discriminatory or outdated language. And I think the 2 pieces I think that really probably mostly align with take-home doses, which we'll discuss today, is really how to create a patient-centered perspective and reduce barriers to receiving care. And I'll just say, as an addiction medicine provider for my career, I think the number one reason I hear why people haven't wanted methadone if I'm being in the hospital or in primary care is just that you have to come every day. So I think we've all probably experienced this. We've probably all lost patients to overdose who could have accessed methadone if it was more user-friendly. And now working in OTP for the last year, on the flip side of things, what I've had the experience of seeing people who have doses and be able to hear the benefits and not having to come every day, just in terms of how they're able to spend more time with the things that are important to them, whether it's their family or their work. And so it's a great privilege to sort of listen to those stories. And it's had a real impact on me as a doctor. But I think to really understand this, in my opinion, to sort of understand what the impact of take-home doses has been, and also what the impact of not having as much access to this in the past, it's really important to hear from a patient. So with that, I want to welcome Kaitlyn Spall to the stage.
I'm much shorter than Ari, so can everybody hear me now? Thank you so much, everybody. So my name's Kaitlyn. Let's see if I can put this. My name's Kaitlyn. I'm a person in long-term recovery who uses substances. I'm a methadone patient and advocate, a recovery coach. I have my bachelor's degree in psychology, and I have all the hours completed for my KDAC. I just got to take that stinking test. When I started methadone in my recovery, it was in 2016. I had left a detox and decided that I wanted to use methadone to be able to stay off of opiates, but it was such a rigorous problem and a process to get onto it. It took me about 3 weeks just to get in. So when I left the detox, I had the option to either go back to the streets, risking an overdose, or try to string out 3 weeks of no use before I could actually get to the clinic. Once I started, I noticed that regulations didn't really lighten up very much. Between the weekly counseling that was an hour, our mandatory groups, and the most important, the timing. If you didn't get at that door by 11 o'clock, no dose for you. Let me tell you that even counseling in my groups had the same thing. I remember waiting one day to get into group, and I was 5 minutes late, so I couldn't dose for the entire day. All of that after I had left my child crying at school without being able to console him, so I was so afraid of missing my methadone dose. The other thing that was really challenging for me was all of the expectations. So I was homeless, living in a family shelter, which had its own rules. I had the Department of Children and Families, and of course, their plan for care that I had to follow, including everything that the methadone clinic wanted me to do on top of their rules, including counseling through a specific and separate domestic violence counselor, mental health counseling, and the hardest one, if I didn't dose that day, I had to find childcare for my children because they couldn't be in my care. On top of that, I had a probation officer that had his rules and regulations, and I had to do everything while working my recovery. Brand new, trying to feel feelings I haven't felt for the first time in a long time, and trying to navigate myself. Daily dosing was something that I had to do every single day. I was not allowed take-home medication. For 6 years straight, I dosed. The criteria at the clinic I was at stated that I couldn't keep my take-home bottle safe because I was homeless, even though I lived in a lock and key apartment with my family because that's what the shelter was. I had a partner in recovery, which They said because he once used substances, he might take my medication from me. And my all-time favorite, I had a medical marijuana card. So I had a doctor who told me that I could use cannabis for my mental health instead of using the very harsh prescription drugs that I could get from the doctor. And because of that, they said, no way, no how. For 4 years, I had nothing in my system but cannabis, and I still had to show up every single day. When I say every day, I really mean it. I remember a holiday, every holiday while I was on Christmas and specifically, I would show up at the clinic the entire drive there, so worried that my 3 children under the age of 10 were going to wake up and see that Christmas tree before I could get back. How nerve-wracking. Who knew what was going to be an obstacle in my way? Daily dosing made me feel like I wasn't trusted and judged. I couldn't keep my medication safe or make good decisions. It made me feel like I couldn't make positive choices about my treatment. And their biggest thing, that I would accidentally hurt myself. I felt like I was unable to advance and I was stuck. It was hard for me to gain employment. The hours of dosing, the 1-hour appointments, and the countless amount of jobs that I lost because I was late, because of things that just happened at the methadone clinic. I was stuck in the shelter with no car because I couldn't get money or move forward. And on top of all of it, the hardest part, my DCF case wouldn't close. They were very adamant about my recovery journey, and all they would look at was the use, nothing to do with the recovery. I was really unable to obtain a better quality of life. I experienced the same hardships over and over again. Even though both my clinician and my medical doctor said, you're the poster child for recovery, I couldn't advance forward. My recovery wasn't mine. I wasn't heard or listened to about my body. I was still sick, unable to stabilize, but I wasn't allowed to split dose because I didn't meet criteria. So I would struggle every single day withdrawing to get my kids on the PVTA bus, towns away, to be able to get them to school and then finally get my life-saving medication. I was unable to advocate for myself, and my recovery was really based off of what the clinician wanted and what the clinic wanted and what they expected. It had nothing to do with what I wanted or how I saw my life. This made my recovery a little hard because chaotic use manifests in the dark and it's hidden in secrecy. I wasn't able to use harm reduction or moderation. I wasn't able to be honest with my counselor to talk about things. I was really going through an identity crisis. I was a recovery coach facilitating recovery groups, but I didn't know who I was. Am I a fraud because I'm on MAT? Am I a fraud because I use in moderation? I didn't know what I was. People would tell me all the time, I'm so proud of you. What were they proud of? I'm not sure. The guilt, the shame, the remorse, it piled up, and piled up. And really, the hardest part was when COVID-19 hit. Everybody went into lockdown, except for my clinic. I still had to show up every single day on time, regardless of who was getting me there or how I was getting there. I stood 6 feet apart from the person in front of me, 2-3 hours outside in the rain, all the weather, all the things outside, 2-3 hours waiting so that I could get my dose. And like I said, everybody else was in lockdown, which means that I lost all my other resources. There went my 12-step fellowships, there went my peer recovery center. All of the things that were helping me stay clean and sober had now dissipated. This left me only one thing. I went back out.
We're trying to get me to so I don't have to lean over so much. Okay, good. Great, that's better. Cool. All right, so we heard about really sort of the negative impact on recovery resources during COVID, which is obviously a very real thing. Thanks, Kate. But I also wanted to sort of bring us back to some of the background and sort of as we lead into some of the language around take-home doses that we're hearing from SAMHSA. Just a quick background. Dee did a great job with this already, but COVID-19 blanket waiver exception, March 2020, saying that stable patients could have up to 28 days of take-home doses, less stable, 14 days. There's really high uptake. See that prior to the public health emergency, it was about 15% of OTP patients in Massachusetts who had, and at the height of the public emergency, 52%. It's really great to hear today. It's 58%, so that's amazing. And this is, you might recognize the font. This is me stealing these slides from last year, which was a great summary of the flexibilities. So a high uptake of take-homes in Massachusetts, 0 overdose deaths from methadone during the pandemic. There's better engagement in treatment, increased client satisfaction, and improved provider satisfaction. There's now pretty wide data, evidence at this point that there was an increased overdoses due to methadone during the pandemic, despite these flexibilities. Also say that there is some suggestion that perhaps for men of color, actually the overdoses regarding methadone had actually decreased, which is especially relevant for, I think, everyone, but especially our clinic in Springfield where we work. This was one study from JSAT that showed that not only were there less methadone, there wasn't signs of increase in methadone-related overdoses, but there was also improved retention and lower rates of positive drug screens during the flexibilities. And I think all this went into the final rule. I think all of this, what we learned from the public health emergency, obviously informed, I think, what we're seeing with SAMHSA. And so I want to just sort of take a moment and sort of drill into the language, especially what they're telling us and the guidance that they're giving us regarding take-home doses. So prior to the final rule, we had the 8-point criteria. We now have the 5-point criteria for take-home doses, and I'll sort of reintroduce you to those now. The first one is absence of active substance use disorders or other physical or behavioral health conditions that increase the risk of patient harm as relates to the potential for overdose. This one's highlighted in red because we're really going to focus in on this today and how do we actually assess for an active substance use disorder. The other is regularity of attendance, absence of severe behavioral health problems that can endanger the patient, absence of known recent diversion, and whether take-home medication can be safely transported and stored, and then really any other criteria that the medical director or medical provider sees fit to include. To speak about this big change, the 8-point criteria versus the 5-point criteria, I think it's really important to sort of look at this and look at the language of it. And so in the past, it said absence of recent drugs of abuse, the recent abuse of drugs, including alcohol. And this now changed to absence of active substance use disorders. And it might seem like a small change at the surface, but it's actually, I think, a pretty large change. And I think what SAMHSA is saying in this change is actually acknowledging that there's a large spectrum of drug use. And I think Kate spoke to that a little bit already. But obviously, I think probably most people in this room are aware of this, but not everybody who uses drugs or alcohol has a substance use disorder, right? If, for example, I think it's something like 60% of Americans drink alcohol somewhat regularly, but only about 10% actually have a substance use disorder, an alcohol use disorder. And we don't do this in our clinic, but if we were to swab for alcohol metabolites, a lot of people would come up positive despite actually having an active alcohol use disorder that would impact their care. So again, I think what we're acknowledging that many people can actually use substances safely in a way that doesn't actually impact their methadone use. And I think we're also being told is we should change the way that we make these decisions. Okay. In the past, with the 8-point criteria, it was like anyone using drugs, and it was really sort of this binary thing based on toxicology screens. It was either yes or no. If there are drugs there, no. Okay, and if there are no drugs there, well, we'll consider it. And I think what we're sort of changing to is just a sort of absence of just a yes or no with a drug or toxicology screen. What we're actually saying is how we should make these decisions is with conversations with patients. There's something easier from a clinic side to just sort of say yes or no, is a drug there. Like it just makes everything much easier for a clinic side. But obviously, as we heard from Kate, this can have a very real impact on patients, especially those who can safely manage their doses. I wanted to kind of just drill in a little bit more to the language that SAMHSA is telling us. So this is from their FAQ part of their website, which is what is actually meant by an absence of an active substance use disorder that increases the risk of patient harm as it relates to the potential for overdose. At the risk of putting a couple of paragraphs of SAMHSA language on the screen and losing you all, I'm going to go for it. I've highlighted a couple of things in red. Cool. The laughs are good. So again, SAMHSA recognizes that individuals in treatment with methadone may intermittently use substances that don't necessarily impact the efficacy or safety of methadone or increase the risk of overdose above that which may occur in the absence of methadone. And then further towards the bottom, we're encouraged to make methadone take-home dosing decisions based on our knowledge of the patient, their patterns, risk-taking behavior, stage of change, and need for engagement with OTP team members. And such, they're really encouraging us again to have an honest dialogue with patients. Just a little bit more SAMHSA guidance. I didn't lose you last time, so let me see if you can tolerate one more paragraph. So again, encouraged to use clinical judgment, encourage us to get the input of multidisciplinary OTP clinical team. And I think a really important piece is the risk of a patient losing access to medication continuity should also be considered. Just as one example, think of a patient who lives 45 minutes away from a clinic, who might be taking care of their ailing parents. Taking away their take-home medication takes away all access to methadone, and think about the risk of that. So we're encouraged to sort of think about both the pros and the cons of take-home medications and also the risk of taking them away. So that was sort of the background and setting the scene. And now I actually want to turn it over to Carissa to sort of talk through what our process is of actually how we assess these patients. So what I'll do is, you want this or should I transition? Working? Good.
Thank you. Good morning and happy Friday the 13th. My name is Carissa Cutler. I have my bachelor's of psychology and my master in social work. I've been doing clinical social work for over 10 years and specifically working with persons with opioid use disorders since 2020, originally starting in a hospital setting and currently working for Behavioral Health Network at our Springfield OTP. So as already mentioned, it was determined that to satisfy SAMHSA's guidance, decisions on take-home doses would really rely on this conversation between us and the client. And when approaching our goal of ensuring individualized treatment and sort of determining where a person falls on this spectrum of substance use, our team initially considered, existing SUD screening tools. And I gotta say, it was fairly quick that I sort of decided that there really isn't a tool in existence that serves the specific need and purpose that we're trying to fulfill here. Also, I felt like other screening tools felt generally cold or stigmatizing in the way that questions were asked. And so really we wanted to consider the client experience and putting ourselves in their shoes. I wanted to think, what would it feel like to be called into my clinician's office because my drug screen is positive? As a clinician, I wanted to make sure that our clients felt more supported than interrogated. And I really wanted our assessment to feel more like a collaborative conversation. So I felt strongly that we really needed to create something new and unique, and in order to achieve this larger goal, while also incorporating the 5-point criteria specifically within our assessment. And so here's a glimpse at what our assessment tool looks like. I've popped a large QR code on there, so in case you wanted to pull it up on your own device, that could be easier. And just so you know, this QR code will be available at the end of the slide as well, just in case you missed it just now. So naturally, the assessment tool does include a section to document specifically on each of the 5 SAMHSA criteria. And while we knew we needed to assess the client's, level of substance use and the other 4 out of the 5-point criteria, these are really the risk factors, right? But when thinking about what SAMHSA is asking us to do to engage in this risk-benefit analysis, we really wanted to consider, where do we begin the conversation with our clients? So we decided we wanted to choose, we wanted to focus on the benefits first, to sort of hear from the clients, tell us what's going well for you, and sort of gather from them the reasons why it would be important to have them have continued access to their medication. So we started there. The next component of the tool is where we assess the person's use to determine whether or not it would be considered, quote, an active substance use disorder. We determined that how substance use disorder is defined in the DSM would probably be sort of the best, most appropriate way to go. So within the tool, we have a grid which lists the 11 DSM criteria as it's written in the DSM, giving the clinician space to incorporate the client's response and direct quotes from the client when we engage them in the conversation. as well as a section to indicate yes or no, whether or not that person meets each of the criteria. At the bottom, we sort of have select one, totaling up how many criteria they meet. And as we know, 2 or more meets criteria for substance use disorder, 2 to 3 being more on the mild side and 6 or more criteria being a severe substance use disorder. So with this, we knew we had a duty to not only ensure the client experience was more positive than negative, but also a duty to ensure our clinicians were sort of as consistent as possible from provider to provider on how they're assessing this criteria. So I decided to create a job aid for clinicians, which sort of helps form these as much as possible non-stigmatizing questions to get each of the criteria answered. I sort of realized that, if you were to try to answer the criteria in order by which it's listed in the DSM, that would feel like a very disjointed interview. So I sort of created the questions to flow more like a natural conversation while showing the clinicians to the right which criteria each of those questions is really answering for their assessment. So with that, we're going to do a demonstration today just to sort of give you an idea of how this looks and feels in real time between clinician and client. And Kaitlyn was very kind enough to agree to help me with this today. Just to note, we find that the assessment tool takes about 25 to 30 minutes to complete with the client for the clinician. And for the interest of time today, we're just going to demonstrate a few of the questions, not all, of course. Before we begin, I just want to note that Kaitlyn's not responding to the questions as her true self, but as representing an example client that we came up with. So in this interview, the example client is someone who has had 13 take-home doses for the past 4 months. Their tox screens have been negative for all illicit substances, followed by most recently, one of their drug results came positive for cocaine. So this prompted the clinician to do the assessment to determine if her take-home doses should be decreased or if they may remain intact. All right. Yeah, come on up. All right. So Kaitlyn, thank you for coming in today. We're here to meet today because there was a recent change on your drug screening, and I just wanted to verify with you, how things are going for you, if you need more support from me, or how much you may or not be concerned with your drug screen results. So the conversation we have today and the questions I'm going to ask you really are just to help reflect on your relationship with substances and whether or not that feels problematic. Do you have any questions for me before we begin?
Are you taking my take-home bottles?
So I'm going to be completely honest with you. That is one possibility. Okay, so with your recent positive drug screen, it's possible that your take-home doses will be reduced to some degree. But this conversation really is to take it a step forward and hear from you and see, is your use problematic? Is it not? Is there concern for your ability to manage your medication? And so depending on how our discussion goes, one result is you maybe need more support and we may have to reduce the number of take-homes. The other result is that maybe there's no major concern and you're okay to continue with your 13. So really just want to get your input to see where you're at. And either way, even if we reduce your take-homes, we would develop a plan for how to support you in returning to 13 as soon as possible and what would need to be done and what would need to be worked on. So does that sound okay?
Yes, thank you.
All right, so first let's talk about how you're doing overall. Can you tell me about your methadone treatment, how that's improved your life or helped reduce your substance use?
Yeah, absolutely. So as you know, I have chronic pain. And so I was in the streets using fentanyl for a long time. And it became, obviously with overdosing and all of that, really hard for me to navigate out there. Since I've been on methadone, I've been able to use that as my pain management. I haven't had to go back to the streets. I have 4 months clean finally, which is, the longest time I've strung together. And so methadone just really, really saved my life.
Great, thanks. Congrats on 4 months. And can you tell me specifically, in what ways does having your take-homes help support your recovery?
Yeah, so, obviously I take care of my mom. She's very ill and I'm her sole caregiver. And so being home in the morning, being able to take my medication right when I wake up and then taking care of her is super helpful on top of course, going to school, working, the kids. My life is just really busy. And then the amount of time it takes me to get here to the clinic. So having take home bottles has really been able to make it so that I can, keep up with life.
Great, great. And why don't you tell me something that's going particularly well for you right now? Something that you're proud of with your recovery?
Well, like I said, 4 months, came up on 4 months, and that's the longest that I've been able to string together. And so I'm really proud for that. But this time around, the reason I think I was able to get that is because I've been able to show up for myself, been able to show up to support groups, meetings, therapy, because I'm not sick, right? And so the methadone has been able to give me that space where I can actually work my recovery and not just put the substances down.
Excellent, right? So can you tell me when was it that you recently used cocaine?
Say it was about 3 weeks ago. Yeah, about 3 weeks to a month ago, I was offered it at a family party, and so that's when I did it.
Okay. And have there been any other times that you've used since that time at the party?
I did use honestly one other time. I was trying to stay up all night. I had exams and all these things to do, and so I did go out and purchase some, and I did use again that time.
Okay. And tell me, about how often would you say thoughts about using cocaine are crossing your mind? Do you have any cravings?
So when I'm using the cocaine, I notice that like my brain wants me to do more, right? Something with that substance in me is, I noticed at the party thinking about, oh gosh, I was only offered a couple lines and I kind of want to go get more. But I was able to use my resources, reached out to my recovery coach. She kind of talked me down. And so I didn't go purchase anything on my own. Same thing the second time when I had gotten it myself. I noticed wanting to go back out and getting a little bit, but nothing intermittent. I don't, think every day like, oh, I wish I could go out and use again today. It's just really when I'm on the substance that I kind of get in those thoughts.
Gotcha. Okay, makes sense. All right. And so as far as the two times you've used and the places you've used or people you've been using around those two times, have you ever felt unsafe in those environments?
No, the first time, like I said, I was at a family party and they were all using the substance. And so I didn't have to worry about it being laced or anything like that. I had seen that they were okay. And so that felt safe for me. And then the next time, of course, using my harm reduction, skills and tools, making sure that I wasn't alone, was able to be in a safe environment. I don't feel like I was unsafe.
Okay, great. I wonder if you can tell me a little bit about your past experiences with cocaine. Have you ever had times in the past that your use has increased, or how many times have you used in the past year, would you say?
Cocaine's never really been like the substance of choice for me that, I've used cocaine, gosh, since my 20s, going out to the bar and, being able to socialize in a social environment. But it's not like fentanyl or heroin was for me. I never put it in a needle or anything like that. It didn't, become out of control or anything. It's just been something that I do here and there.
Great. All right. So, right. So it sounds like there have been times in the past where you've used intermittently. Sounds like it's never been a problem or major concern. The fact that you've used it, twice in the past month. However, I do want to acknowledge you were able to bring in some coping strategies to control it and not use excessively. Based on what you're telling me, I'm not majorly concerned. I wonder if we can just sort of, instead of doing our monthly sessions, maybe I'll check in with you twice a month. Every other week I'll give you a call just to sort of monitor and make sure that things are staying at this non-concerning level. Does that sound like an okay plan for you?
Yeah, perfect.
All right. So if that sounds like a good plan, I just want to let you know what to expect next. I'm going to bring what we discussed today to my supervisor, and she and I will sort of make a final decision about if you can remain at 13 take-home doses or if this would need to change. You can expect to hear from me by the end of this week on that decision. And just so you know, anytime one of your tox screens shows positive for something in the future, we'll just sort of revisit this conversation that we're having today. Of course, just to make sure that you're doing okay or if you need more support. Does that make sense? Do you have any questions for me about that?
No, that sounds great. Thank you so much for being able to have this conversation. And, I was able to be honest because of your approach with it. So thank you so much.
Great. Thanks, Caitlin. All right, everyone get Caitlin again. Yeah. All right, that was wonderful. Yeah, keep the 13, yes. All right, so the next components of the assessment tool are, where we document on the SAMHSA risk factors. Now we're able to confidently answer the first one about substance use disorder. You know, it feels like, between clinicians and nurses, we'll sort of have a sense if if there's any concern for the other risk factors. And it feels like, the clinician could incorporate that in their assessment questions as needed. Otherwise, they can typically answer those on their own after the client has left. There is a section for additional considerations, which would be sort of those other compelling reasons why a person should maintain their access to take-home medication. Because as SAMHSA outlined, we want to make sure we're considering reasons why revoking someone's take-home doses may be detrimental to their treatment or ability to dose daily. We saw with the example with Kaitlyn, the distance from the clinic, responsibility as a primary caretaker, as well as her schedule with college and work would be factors to consider. She might not be able to dose daily if we were to take those away. I also want to note that, completing our DSM criteria assessment, how many criteria the person meets will indicate the different degrees of substance disorder, mild, moderate, severe. And so this is what we consider along with the other risk factors when weighing against the identified benefits of having take-home medication. So lastly, in our assessment, a determination is made whether the person's take-home doses can remain intact, if they'll have to be reduced due to concern for risk factors, or for complicated cases, we could send it up to the multidisciplinary team meetings for further assessment. At the very bottom, we have a section for the clinician to indicate sort of the plan moving forward. So depending on the determination and what was discussed in the assessment, as you saw with our example, we're going to increase counseling. We're going to continue to monitor the drug screens and sort of take it from there.
Okay, is this back on? Good. It's working. Great. And so I think Chris and Kate just gave you an idea on how to do this on a sort of patient-specific level. How do we assess folks? And I want to spend a few moments talking about how we might do this or how we have done this on a clinic-wide level. And so the first thing I want to talk about is just how we rolled this out at BHN. And so the first thing in February, when we sort of learned of the final rule guidance, we had leadership meetings 4 times. And really what we did at these meetings was really to decide that this was a project that we felt really important to take on. We built the workflows of how we'd move forward once somebody tested positive for a substance in their toxicology, and really we developed this assessment tool. The next piece that felt really important was just to bring it to all the staff and sort of teach everybody about this. So lots of things that happened in a short amount of time. Lots of people have been working in OTPs, some of them for 20 years. And if we think about for the average OTP clinical person like this, these represent drastic changes. And so we started with why and sort of educated the team on why we're making these changes, sort of educated them on the public health emergency data, as well as the SAMHSA guidance, what we're actually being told to do. We taught the tool, we practiced the tool, and then sort of been honing this in an ongoing way with clinical meetings and supervision, as well as MDT rounds. So that's how we rolled it out. And then I think there's also a question of like, how do you do this on a clinic-wide level? One of the nice things about 42 CFR, the final rule, is it really highlights provider autonomy. I think this is especially great when we think, for example, about starting doses, and now we can use our clinical judgment and sort of dose people aggressively when it's indicated. So I think a lot of part, when you read sort of the final rule, you're like, great, like these decisions rest with me, the medical director. And so I was like, in general, I've said great, and then there's an element of how am I supposed to possibly make, individualized care decisions for 1,000 patients in a clinic? And so I want to talk about that briefly. 1,000 patients. And I think the short answer really is delegating. And really there's clear language in the final rule about delegating. It says that the medical director may delegate specific responsibilities to OTP medical providers, as well as licensed and credentialed healthcare professionals. And I think this really is a team thing. And again, we educated it broadly, I think both because everybody needs to know, but we also need everybody's input. And so what I thought I would do in just a moment, actually, is sort of run through the 5-point criteria and talk about how we do that and how we do that as a clinic. But first, I just wanted to sort of just share a couple of just sort of bullet points on the BHN take-home dosing policy or take-home bottle policy. There'll be a QR code at the end to sort of link to this as well. But for purpose right now, the way our policy reads, and it's actually read for a while, is that to have 13 or 27 take-home doses, you have to have no evidence of an active substance use disorder. Obviously, if there's really compelling reasons, otherwise we do make exceptions. You need to have improving SUD to have 6 take-home doses. And these are really, these are assessments that are driven by clinicians, as you just saw with Chris and Kate. But if we look at the other 5-point criteria, because we have an amazing nursing staff, I want to give a shout out to Hazel Barrett for the great work he does as Director of Nursing in Springfield. Because I really think like we lean on our nurses so much for this. I mean, I think they have the people who have eyes on patients every day at the window. And so just to go through this for each of the points and sort of highlight who in our clinic we delegate these responsibilities to. Absence of active substance use disorder we shared is really a clinical piece. And then physical behavioral health conditions often falls to the medical provider if you're seeing somebody for an intake or an annual, or you get records from the hospital or just hospitalizes, or on the medical provider to sort of consider and make decisions based on that. Attendance is really a nursing thing. You know, they're sort of at the window every day and monitoring people's attendance. Absence of severe behavioral health problems. Sometimes we see this at the nursing window. If there are severe behavioral health problems, that'll often show in the clinic. And also hospitalization record reviews. Absence of known recent diversion. It's usually our nurses who first see this when bottles aren't brought back, or there's sort of some emphasis on evidence of tampering. Whether meds can be safely transported and stored. It can be nursing, clinical, and then any other criteria. And then, you know, we really do multidisciplinary rounds for complex cases. And so we don't really have the time to sort of work through how we do this on a workflow level, you know, like how is this all happening in the clinic? I think it's beyond the scope of today's talk, but we will have these QR codes up again towards the end, where how do we sort of approach our workflow when people do test positive, as well as our take-home bottle policy. I want to quickly talk about impact on our staff. Again, this was in many ways a big change for OTP clinic staffs. And I think, you know, their big changes actually happened in March 2020, when people could either be 27 or 14 based on whether they were stable or unstable. At least in our clinic, it wasn't always clear how we were making these decisions. Like there was no uniform sort of criteria that we had. It was sort of a little bit ad hoc. And that was the big rationale for us doing this. And I would say that when we sort of started this, there was some confusion on nursing clinical staff, or why does this person keep bottles? Why does this person not? And so our hope, you know, I think the primary outcome is really to make sure there was really fair and equitable decisions on take-home doses for our patients. But a secondary outcome we're really hoping for is that it was clearer for our staff in terms of how we were making these decisions, and they felt good about it. And so I just want to run through some quick pre-post surveys we did, starting when we first sort of launched, before we launched in February, and then 2 months later. You know, I feel confident in my understanding of our take-home bottle policies. It applies to patients with positive take-home, positive toxicology screens. We saw really an increase in the amount of people who agreed with this. I believe that our take-home policy is well aligned with BSAS and SAMHSA. My role and responsibilities in the clinic's take-home bottle policy is a good match for my training and qualifications. We want to make sure that people were all comfortable with these processes that they were doing. And then I'm happy with the role that I play in our clinic's take-home bottle process, which you see that everybody agreed with after the intervention. So I wanted to just share that briefly, because I think this had a positive impact on our clinical staff, this process. And I think what I really actually want to leave you with, and I think what's most important, is the impact that this has had on our patients. And so I want to then sort of, for the final comments, to sort of hand it back over to Kaitlyn so she can tell you her thoughts and reflections.
Just have to find my spot. Please hold. Okay. All right, so my reactions for this tool when doing it, of course, was we have come a long way, but we still have so much work to do. The situation that I had, just very briefly, because it's a little bit different, looked a little different than kind of what me and Carissa went over. I was in a position where I had a certain amount of take-home bottles. My clinician advocated for me to get more because I live an hour away from the clinic. I work multiple jobs. I have kids. And so even with sporadic use, our conversation led to me being able to increase my take-home bottles. This just kind of outlines the things that I was given. So the positives that I found from this tool in this process was the psychoeducational piece. So it leads to treatment discussion, dialogue for open reflection to see how much use and patterns, etc. I was able to actually talk with my clinician and make it so that my recovery was based off of the honest truth. Other parts of other than a toxicology screen. That was something that was really new to me. It's super important since that's all that DCF or my probation officer ever wanted, including my last clinic making it so important. That's really something that I honed in on all the time, the anxiety around a tox screen. This tool gave back some of the power to me, the client. It made it so that other changes can happen. And it doesn't have to be what the clinician wants or the clinic wants. It was what I wanted my recovery to look like. And the most important part of it is that not all substance use is problematic or defined as a substance use disorder. We're moving away from this abstinence only model. The feedback that I had for it is that it really takes honesty and rapport with the clinician. If your clinician is reporting to DCF or to a probation officer, it might be hard to have a conversation with them about your use. Also, it depends on how long you've known your clinician, how comfortable you are giving them all the information about yourself and outing yourself, so to speak. Another thing is the clinician's bias. So things like a parent using drugs instantly equals neglect in a 51A, and how a clinician defines recovery. Another point was that the DSM criteria is imperfect. There's of course subjective parts, including things like how much time and money people spend on substances. If I'm a working person, I might not have to go out and get my money some other way. But if I'm a person that has no income or limited income, that might change, right? And that not one size fits all. Another really important fact was, how does the clinic interpret things like regulations and active substance use disorder? And finally, the clinician's deliverance and the interpretation. So the way that a clinician talks and asks the questions is going to be really important, and the interpretation of certain things. Like earlier when we discussed, how often I use in cravings. Does that count as I have cravings or not, right? It depends on what's interpreted. So there's still so much stigma around substance use, especially within the whole world, but clinicians and everybody else, that makes it really hard to do a tool like this. There's a lot of education that needs to happen, a lot of change in thinking that needs to happen. There's still a lot of advancing forward in this thought process. So this here is my methadone in recovery today. So the first and most important thing is I'm in charge of my recovery. When I first came to the clinic, they raised my dose with no stigma. I got a split dose, and quickly I told the doctor, no, I can't have that. I don't qualify, as if I was the doctor. I was able to set when I wanted to see the clinician in the groups that I wanted. I was able to say, you know what, I think weekly clinician appointments was good for me, or I think once a month is good for me. That was really important. There was no more guilt, shame, remorse, or fear. I had my first harm reduction conversation. They told me to stop counting the days and to get a calendar. Write down how many days you used that month. Did that blow my mind? I was able to talk with my clinician, and I wasn't afraid of her reporting back to anyone. Today, I have 13 bottles and a split dose, which means I'm trusted with 27 take-home medications. The nurse, at first, I remember when the nurse had given me my first set of bottles, I told her, you're wrong. I have cannabis in my system, so I can't have these. So to be trusted with 27 take-home medications is mind-blowing to me. And most importantly, my substance use is not chaotic. It's not in secrecy, so there's no fuel to the fire. I'm able to have conversations that lead me to be able to reflect on myself, when I'm using and how I'm using. And of course, I haven't used a needle in 8 years. So I currently work 3 jobs in the recovery and mental health field. I don't have to dose daily. I don't have to worry about my hours or appointments. I'm able to share my experience and help others by giving back. And I'm only able to do this because of my take-home bottles. I'm able to advocate for change, especially not only abstinence, but a harm reduction saves lives. I've worked in detoxes, inpatient, residential, outpatient, and outreach programs. I have 15 years in direct care staff, starting from peer all the way to clinician. My favorite thing now is just last weekend, I hosted the third annual Sober in the Park. This is an all pathways to recovery where everybody comes together to show the community that there's multiple pathways to recovery. And the old thinking of 12 steps, abstinence only, is just that, old thinking. I get to speak at conferences and meetings like I am today. What I really love is that I get to spend the holidays with my kids. We get to go on vacations. As you can see here, this is us in New York City at last year's Liberate Methadone Conference. I have a home and a car for my family, so I can make it that 1 hour drive to the clinic and 1 hour back when I need to. And the most proud that I have is that my DCF case and my court cases are closed. I'm completely scot-free. All of that just to say that my quality of life has improved tenfold.
Great. So I think we have some time we have 10 minutes for Q&A. Here's some QR codes as promised. So yeah, please come up. We'd love to hear from you.
Hey, it's me again, Phoebe Cushman from Spectrum Health Systems. Thank you for this really fascinating, beautifully put together and inspiring talk. I want to say that before I make my comment, I want to say I love my clinician colleagues, and I know many people in this room are clinicians. I do want to acknowledge that one of the pieces of negative feedback that we often get from people in recovery, people who are advocating for expanding methadone access, is that they see the frequent check-ins with clinicians as a barrier and as punitive. And I know even among the wonderful clinicians I work with, there's a little bit of tension as we break down the barriers to take homes about, well, how engaged are they with the clinicians? And, the conversation that you demonstrated was this sort of beautiful coming together, meeting of the minds. Clearly, the client wanted to meet with the clinician. That's not always the case. And some people really see it as like, oh my God, I have to do that again in order to just keep my take homes. How do we make peace with that? And how do we also help our clinician colleagues kind of maybe have more of a range while we keep people safe? And also, in this case, it's not just about safety, it's really a true checking in.
Hello. Is this on? Okay. Thank you so much for the question. And we agree. And I think the other great thing about the SAMHSA guidance that came out is that counseling is no longer mandatory. And so we also incorporate, conversations with our clients who, if it makes sense, like, let's not force this on you. We're here for you. I'll call you once a month just to see if you need anything. And, we can have sessions as needed. And so I think the more that we sort of incorporate that lens, and also when we do have to check in with them, if they want to maintain those take-home doses or increase, they will most likely be willing. And then once we have them in our office, if the conversation goes kind of like how you saw today, I think there'll be a little bit more reception to that. But it's a very important question. And I agree that we shouldn't be sort of forcing counseling on people, that, access to methadone shouldn't rely on that either. So great point. Thank you. Oh, and Kaitlyn will say something.
I just want to say real fast from like the patient perspective of how I want to get into a clinic, into an appointment like that, is I think that like Carissa saying, the more that we do this and the more we change the climate of our clinics, the better it's going to be. I've seen phenomenal social workers and clinicians who really are working on this, no stigmatizing idea, but we still have so much room to improve, right? So I think the more that you trust your clinician, the more that your clinician's not just going to punish you and this isn't a punitive thing, that's really going to set the stage for these conversations to be able to happen.
Yes.
Hi. Thanks. This was amazing. Can you hear me?
Yeah.
Is that working?
Yeah, that's
Better.
good.
Linda Kinch, I'm medical director at Gifford Street CTC, and thank you. That was a mind-blowing conference. Our clinic, for our group of clinics has been the one designated to really be pushing take homes, and it's been wonderful. And we've been sort of okay. We've been, assessing, is this just a positive test, or is this really an OUD? And everything's been going really well. The thing that has been driving me nuts is getting the urine toxicology, and we are, a lot of urines are coming back negative methadone, positive metabolites, and I have the lab on speed dial, and the metabolites seem very consistent, and the methadone's there, but it's under the cutoff. And I am just in a quandary. Our lab director thinks it's kind of problematic, but there's not a lot of direction. And I don't know if other people are running into this and how they, because I'm looking at these people, and there are superstars, and they're on 27 take homes. And, he's saying there's something wrong. The methadone levels shouldn't be this much lower all of a sudden. So I need help with that. I don't want to take them away.
Yeah, it's working right. Yeah, that's a great question. I guess. I'm glad that you're talking to your lab provider and just trying to make sure that you're interpreting in the right way. I think is always the most important thing. I think these screens get misinterpreted so often. So just to first acknowledge that you have somebody on speed dial, who's a toxicologist who can help you answer that question. I do think, I think I'm a big believer in like sort of liberating and making more take-home doses, appropriate for folks. And I think on the other hand, we're still, watching out for diversion. And so we definitely have seen some people in our clinic whose methadone levels weren't appropriate for the dose that they're on. And we've seen changes since they started getting bottles, and we do pull them back because I think, I think we still want to take diversion seriously. And so I think my best answer is, I think if you're getting feedback from the toxicology folks that there should be higher levels than there is, and then are present there, I think we still have to take that, seriously and pull people back. That's my best answer. Callbacks, great. Yeah, thank you. Good point. Yeah, callbacks can be really helpful for that too, and just sort of, call them back, halfway through and make sure that they have their appropriate doses. So thanks. Another safeguard.
Yeah. Oh, Peter Friedman, Bay State Health, very inspiring. Thank you so much. It's really heartening after, 25 years to see that we're really starting to make some progress. I had a question about the substance use disorder criteria. I noticed that the physical dependence criteria are still on there, the tolerance and withdrawal. And of course, anyone who's on chronic opioids is going to meet those criteria. So how do you sort of finesse that in doing your assessments?
I'll just answer real quick and then hand it to Chris. Yeah, everybody who's on methadone is obviously going to have tolerance and dependence. And I think one of the ways we think about it is like, are they using some degree of fentanyl above and beyond that, by which when they only take their methadone, they have, withdrawal symptoms from that. And so I think at least sort of clinically, that's how we make sense of it. Are they using so much fentanyl that they, when they only use their methadone, they have withdrawal? I'm not sure if you want to add anything from the clinical side.
I guess, yeah, just the development of the questions to get those pieces answered. And, we do these assessments for whatever substance came up positive in their drug screen, but specifically asking about their use of the substance, if they don't use, are you experiencing withdrawal symptoms to the extent that it impacts your life? Because I think that's the other specification in the DSM we noticed. But yeah. Next question.
Thank you. Michael Beerer, Boston. Thrilled to be here. Very moved by your work and by your choice to use this change to make care more patient-centered and collaborative. So it was beautiful, quite moving. My question is kind of along the lines of Peter's and the criteria you're using for the definition of SUD. I mean, you could ask, is there any distress or dysfunction in the last 12 months? If the answer is no, you kind of have, can't you avoid the whole schmagegi? Not that you want to avoid it, because you are doing beautiful patient care and you're taking care of a lot of other issues by having that collaborative discussion. But just in terms of maybe the next step, it sounds like that was an active decision. And if you could comment on that.
Yeah, I love it. And I think, a part of this is sort of, we have that will sort of audit our charts, right? And so we really want to document that, like, this person really does not indeed meet the criteria for substance use disorder as is defined in the DSM. And if we keep our questions a little too simple, I think that might be problematic. However, I don't disagree. Like, it shouldn't have to be this huge thing. But really, and thinking about the DSM, it's sort of, how is this substance impacting different life domains? So sort of going through those real quickly. And I think it's important to note that, yeah, the DSM does not require you to be completely abstinent from substance use. So.
Steve Jones from Western Mass. Great presentation. Your clinic is located in Springfield.
Correct.
That's the first district of the U.S. House. And you have a very powerful representative in Richie Neal, who has been very resistant to requests to co-sponsor MOTA. So I would ask as a request that you organize as much as you can to get people to tell him that this is an important step. The second thing I wanted to ask is, say you were able to transport yourselves from Springfield to Paris. How would you change how you react with a client with a positive urine test for cocaine if you were operating in a place under different rules?
I'm going to sort of answer personally. I mean, I think we're trying to do everything by patients while keeping our clinics open right now. So it's a little hard for me to get out of the headspace of what the guidance is from the feds. So I'm sort of going to answer personally. I think I would have much different conversations in Paris. If I worked in Paris, France, it would probably look very much just like, out of curiosity, what the other sort of speaker suggested, which is like, how are you doing? Is this chaotic? Do you need help? How can we help you? So I think it would have a different tone. And I think what we're trying to do is just bridge that gap and sort of maintain the tone and the feeling while, living into what we're being told to do. Final question.
That's pressure. So I'm Matt Rogalski. I'm the medical director for a couple of different CTCs for Acadia, Woonsocket, Fall River, Wareham. The one plug that I wanted to make in the question is, how do you deal with, as you're doing your assessments, patients who are actively substituting? We'll all have tons of patients who come and they say, well, I use cocaine because I didn't want to use opioids, even though that's what my cravings were. How do you work that within your assessments and sort of spin that forward and manage that going forward?
Yeah, so I think as clinicians and engaging in this assessment, we're going to sort of tailor our responses and our interventions to, sort of what we discover from the assessment. So we might increase supports for that person because, that sort of indicates some level of, do I have control of this or not? I'm not sure that person would, fully meet the criteria based on all the other questions and whether or not their doses would have to be impacted or not. But again, sort of increasing counseling is one of the common responses we have when we do these assessments. If we find anything that someone could use more support.